Diagnostic Studies of the Cardiovascular System. The learning objectives for this module include describing the purpose, significance of results, and nursing responsibilities related to diagnostic studies of the cardiovascular system. Only a few selected diagnostic tests will be described in this module. It'll be the student's responsibility to review the additional cardiovascular diagnostic tests as outlined on your course syllabus.
There are several blood studies that can be drawn on patients that can provide information on their cardiovascular system. CK-MB is one of the cardiac markers. CK-MB is usually elevated when there is myocardial tissue injury. CK-MB levels rise about 3 to 6 hours after the onset of symptoms, peak at about 12 to 24 hours, and return to baseline within 48 hours after the patient has had a myocardial infarction. Troponin is also a cardiac marker. It is a myocardial muscle protein that is released into circulation after injury or infarction. Normally these levels are very low. They are detectable within 4 to 6 hours of injury, peak at 10 to 24 hours, and can be detected for up to 14 days. Serial sampling is needed, usually with 3 blood draws approximately 3 to 6 hours apart. C-reactive protein is a protein that is produced by the liver during peak periods of inflammation. It is typically thought of as an independent risk factor for coronary artery disease and is used to predict the risk of future cardiac events in patients who have unstable angina and have had a previous myocardial infarction. BNP stands for beta-type natriuretic peptide. It's released from the ventricles and is used as a cardiac marker of choice for determining whether the patient has dyspnea related to a respiratory problem or a cardiac problem. So typically a BNP greater than 100 indicates heart failure. N-terminal probrain natriuretic peptide is secreted in the ventricles and is more sensitive but less specific than BNP as a marker for heart failure. Cholesterol is a structural component of cell membranes and plasma lipoproteins. When that's elevated, it's increasing your patient's risk for atherosclerotic heart disease. And triglycerides, which are the main storage form of lipids, also increase your patient's risk for cardiovascular disease.
Additional diagnostic studies can include ECG, which some people refer to as EKG, but this can determine abnormal heart rhythms. It can determine if there has been myocardial injury or if the patient has had a myocardial infarction. An echocardiogram is an ultrasound of the heart, and this can look for congenital defects, wall motion, and will also determine the patient's ejection fraction. This can be done transthoracic or transesophageal. A cardiac catheterization or angiogram can measure the pressures within the heart chambers as well as the ejection fraction, but typically contrast dye is used for this procedure. So this can have potential risks for patients who may have some chronic renal insufficiency, and we'll talk more about the cardiac catheterization in upcoming slides. A stress test also assesses the extent of cardiovascular disease, and it'll evaluate the cardiovascular response to stress, such as exercise. Cardiac catheterization may also be referred to as cardiac angiogram. You may also hear it referred to as percutaneous coronary intervention, and that would be if the patient is going to have angioplasty. A cardiac catheterization can be done for diagnostic purposes, and that's where they're going in and they're evaluating the ejection fraction and they're looking at the pressures within the heart chambers. But it can also be a treatment or an intervention if they decide that the patient does need angioplasty. So percutaneous transluminal coronary angioplasty, or PTCA, it's referred to. So you can see if they go in and they find plaquing of the arteries, they will inflate the balloon. They will then place the stent and leave the stent in place. So anytime someone has a stent placed, they will need to be on an antiplatelet aggregate or an anticoagulant for the rest of their life. During a cardiac catheterization, A small flexible tube with a camera is inserted in through an artery. It may sometimes be done through an artery in the leg, and sometimes it is done through an artery in the arm. It depends on the physician's preference as well as the patient. But a cardiac catheterization can be done to the right side of the heart or the left side of the heart. If it is done on the left side of the heart, you will be able to evaluate the aorta, the aortic valve, and the left ventricle. If you're going through the right, you'll see the vena cava, the right atrium, and the right ventricle. During the cardiac catheterization, an image will be projected onto a screen, so the physician doing the procedure can visualize what is happening. Dye will be injected, and on the screen they'll be able to see the occluded areas within the heart. You can see on the picture on the right that the coronary artery has opened and that blood flow is restored after they did angioplasty and placement of a stent. This image shows you how the positioning of the stent will occur. The balloon is inflated, it expands, and then the balloon is deflated after the stent is left in place. So when preparing a patient for cardiac catheterization, they need to be provided with information regarding the procedure. There will be a consent form that needs to be signed. As a reminder, it's the physician's responsibility to explain the procedure in depth to the patient. It's the nurse who will supplement the information regarding the procedure, and the nurse can witness the consent form. Typically, the patient will be NPO for a certain amount of predetermined hours prior to the procedure, and this is typically determined by the physician who is performing the procedure. The patient will have to have their anticoagulants discontinued several days ahead of time, and you'll have to monitor their lab values. So prior to the procedure, you're going to want to know what the patient's hemoglobin and hematocrit are. You're going to be looking at their electrolytes. We're really going to want to make sure that their magnesium and their potassium are within normal limits. We don't want to have any dysrhythmias potentially occur during the procedure. We're going to look at their coagulation profile, so we're going to be looking at their PT and INR, especially if they were on anticoagulants prior to the procedure. We want to make sure that these are not too high so the patient does not have risk for bleeding during the procedure. We can type and cross-match our patient for 2 units of packed red blood cells. In the event that there's blood loss during or after the procedure, we'll have that readily available on hand to administer if necessary. There will be preparation of the site, so if we're talking about a groin site, they will need to have the groin site clipped if there's hair present. They will have a scrub, typically prior to them going down to the surgery site as well as at the surgery site. And we have to make sure we know about any allergies they have. We have to worry about iodine allergy and our patients that have renal failure, because they will be getting a dye during the procedure, and we have to worry about risks for allergic reaction or potentially worsening renal failure because of the dye. Post-procedure, the patient will have limited activity. Typically, they will be on bed rest with their head up no more than 30 degrees for several hours. After the procedure, we would be monitoring for any arrhythmias. We would make sure that we are frequently observing the insertion site, whether it's in the groin or the arm, for hematoma. We'd be watching for any signs and symptoms of hemorrhage. And we're going to frequently monitor that insertion site for potential occlusion. So we're looking below the insertion site to make sure that that person has a good pulse, that they have no numbness or tingling, that there's been no color changes, and we can compare the right side to the left side. We can monitor for any signs and symptoms of dye allergy. Typically after the procedure, we're going to be pushing fluids, whether it's PO fluids or IV fluids, and that's to help get that remaining dye out of their circulation. We're always monitoring their electrolytes, and we want to make sure we're monitoring their intake and output. So we're probably pushing fluids, so we want to know how much is going in, and we want to make sure that they are having enough out as well.
As with any invasive procedure, there are risks for complications. Some major complications post-cardiac catheterization could be abrupt closure and vascular injury. A person could suffer from an acute MI or a stroke. There's a possibility that if a stent is placed, that there's embolization that builds up in the stent and that the stent becomes plugged. Because we are maneuvering equipment within the coronary arteries, the person can have coronary spasm, which can present with chest pain. If during the procedure there is a complication, or there is a tear in the artery, or they get in and the artery is completely blocked, or a blockage is longer than they can fix with a stent, the person might need to have emergent coronary artery bypass surgery. There's also risk for dysrhythmias anytime we are manipulating within the heart.
In the previous slide, I mentioned that there could be vascular complications. The vascular complications are listed here. The most common vascular complication is hematoma, followed by pseudoaneurysm, retroperitoneal bleed, AV fistula, and femoral artery occlusion. A hematoma is a mass of clotted blood that forms under the tissue. It is the highest complication that can occur. 93% of people who have a cardiac catheterization can develop a hematoma. Typically, patients will have pain and tenderness, bruising at the site, and you will be able to palpate a bulging mass. If a hematoma develops, your nursing interventions would be to apply pressure. The length of how long you apply pressure can vary, but it could be up to 20 minutes. You would continue to assess vital signs every 15 minutes after this occurs. You will assess the size of the hematoma every 15 minutes as well after you are done holding pressure. You'll measure and outline the hematoma so you can document its size and you can watch to make sure it isn't getting any larger or any smaller. You will be notifying the procedural physician, and you should note that a hematoma can develop both before and or after the sheath is removed. Sometimes the physicians will order a femistop to be applied. There is a picture here for you to see, and basically this continues to apply pressure over the hematoma to help prevent it from getting any larger. Someone who develops a hematoma is at risk for nerve compression and vessel compression, basically because of the enlarged hematoma in that area. Depending on how large it is, it can block blood flow to the lower extremity. It can also impact nerve function, and compartment syndrome is a rare side effect that can occur from hematoma. Hematomas can develop from improper sheath removal. It can also happen from patients being fidgety after the sheath is removed or not following the bed rest restrictions. It can happen though while the sheath is also still in place. A pseudoaneurysm is a local dissection or tear in the inner wall of the artery. You can see the image here of a pseudoaneurysm. So basically there will be an extravascular hematoma that will develop and the vessel will be enlarged. Patients experiencing a pseudoaneurysm will have tenderness in the groin. As you are checking the groin site, you will be able to feel a palpable and pulsatile mass. If you were to listen with the bell of your stethoscope, you would hear a bruit as well. Nursing interventions will include vital signs and site assessment every 15 minutes. You would be expected to notify the procedural physician, and you might expect to get an order from the physician for a groin ultrasound with a possible thrombin injection. Retroperitoneal bleed, which only happens in 4% of patients who have a cardiac catheterization, is a very serious complication. A retroperitoneal bleed is defined as blood entering the retroperitoneal cavity through a small hole in a vessel. Patients will typically complain of moderate to severe back and flank pain. At some point, they should begin to have symptoms of hypovolemia and hypovolemic shock. When they complain of pain, the pain is typically not relieved by analgesics, and you will all of a sudden begin to see unexplained hypotension. They will continue to have hypotension or have recurrent hypotension even after they have received fluid boluses. One of the very common signs and symptoms that patients will have will be this urge to have a bowel movement. They will feel like they are going to defecate in bed and will be asking very frequently for the bedpan, because you have to remember they're on bed rest restrictions. So if you put them on a bedpan, they will not be able to have a bowel movement, but yet they will feel like they really have to go. So this is oftentimes a very significant finding that can alert you to the fact that the patient may be having a retroperitoneal bleed. Sometimes it's difficult to notice this on examination, especially if the patient is obese. If it is determined or you're suspecting that the patient has a retroperitoneal bleed, vital signs, site assessment, pedal pulses will be every 15 minutes. Neuro checks, you'll want to make sure that the procedural physician is notified, and you can expect that they will be ordering a CT scan to rule out the bleed. If they determine that there is a bleed, they may do a surgical intervention to control and stop the bleeding, and you will be monitoring their hemoglobin and hematocrit. You can see by this image, if you have an obese patient or someone with a larger abdominal cavity, it can be a little more difficult for the nurse to determine that the patient might be having a retroperitoneal bleed just by physical assessment. It may also take longer for the patient to experience any signs and symptoms because they have a larger abdominal cavity. Things to keep in mind regarding the retroperitoneal bleed is that a person can hemorrhage 1 to 1.5 liters before they show any signs and symptoms. Signs and symptoms might not appear till after the sheath is removed. If you're monitoring hemoglobin and hematocrits, you could consider that there would be a bleed if you see a greater than 5 to 6% decrease post-procedurally. If someone does have a retroperitoneal bleed, 73% of those patients will require a blood transfusion, and 10% of those patients may die during hospitalization. A CT scan and an ultrasound will show you that there's a hematoma, but it is difficult to tell just by a CT scan and ultrasound if there is still some amount of bleeding from that site. About 3% of the population can develop an arteriovenous fistula or an AV fistula. This is an abnormal connection that forms between the artery and the vein at the femoral site. Patients will typically have swelling at the site, pain in their leg, there will be a new bruit, and they may have signs and symptoms of high cardiac output or heart failure symptoms because of the shunting of blood into the venous system. Vital signs will be every 15 minutes. You'll be assessing the site and the pulse and notifying the physician. You would expect that they would be ordering an ultrasound of the groin. Arterial occlusion is also a very serious complication. Thankfully, it is less than 1% of the population that will experience this. And this is when a clot forms in the femoral artery system. You would expect to see diminished pulses below the insertion site, and you would confirm that you have an absent pulse by using the Doppler. You would see pain, pale, coolness, and numbness and tingling in the affected extremity. Vital signs would be every 15 minutes, along with site and pulse checks. You would be notifying the procedural physician, and you would expect a lower extremity Doppler. If it is determined that the person has an arterial occlusion, you would expect that they would have a possible surgical intervention or be getting some thrombolytics. To refresh, signs and symptoms of hypovolemia can include tachycardia, hypotension, decreased output. The skin might be pale, cool, and mottled, and the patient may be diaphoretic. Resulting from loss of circulation or intravascular volume, your patient can go into hypovolemic shock. One of the ways to determine that someone is going into shock is by watching their mean arterial pressure. As the mean arterial pressure drops below 60, this is when you will begin to see many of those signs and symptoms of hypovolemia.